Our next panelist, who will also have about 5 minutes to speak with us, is Christopher Barsotti. He is a community practice emergency physician in Western Massachusetts and Southern Vermont who recognizes the potential for physicians to leverage science and their professional accountability in the interest of public health and safety. He co-founded and is current CEO of the American Foundation for Firearm Injury Reduction in Medicine, otherwise known as AFFIRM, a novel physician-led 501c3 public charity that funds firearm injury prevention research through private sector financial partnerships. So please join me in welcoming Christopher.
Thank you. So it's a true honor for me to be here presenting to you. I came to the space of firearm injury prevention as an end user. I work in community practice in a rural area. And the largest hospital I work at is a level 3 trauma center and serves about 65,000 patients a year. We see all the trauma that happens in this large area. I also work in satellite hospitals that have no backup whatsoever. So there's no psychiatry, there's no neurology. And so because we have a relatively captive patient population, we see people that present at every stage of the disease process. And practicing in an area with a lot of gun ownership, guns come up a lot. And so myself and my partners have intervened on cases where we thought there was a chance of mass violence or intimate partner violence. We've missed some, and we've had people come back. So we've seen the perpetrators, the potential perpetrators, we've seen the victims and the secondary victims. And at a certain point, we keep getting these cases. We need guidance as a community practice physician. And so I decided that I go to my college and try to find out, well, what can we be doing to advise me in practice to identify and treat these people? And I realized that there wasn't any guidance. As an emergency physician, it wasn't a part of my training. And I realized at a certain point that, well, in order for us to get guidance, we're going to have to research. And I couldn't believe there was no research money for this. And I have a disclaimer to make, and that's that I started this organization with Dr. Megan Ranney. And it comes down to this. When I started looking into research funding, this is from JAMA from a number of years back, that most comes from the private sector, some comes from CDC and NIH, and then charitable foundations. And when you think about when I started looking for funding for gun violence prevention research, I couldn't believe there really wasn't any. So the biotech and pharma have no incentive. Charitable foundations donate almost exclusively for firearm injury policy. And the CDC is, as we know, not present in the space. NIH does fund some. And then there's some money from the states and municipalities, but it's just not enough. And so the idea was that, well, look, this is a problem. And we can either continue to talk to each other for 22 years and get no advancement with federal funding, or we can do something ourselves. So the idea is to aggregate all these private sector sources and bring them together and then connect them to the people who have the best expertise, which is essentially our medical societies, our professionals, and each other, and then distribute the money to the people who can do it, and then tell us what to do. And so that's my disclaimer. And so regarding identifying people at risk, so when I trained in emergency medicine, this was the paradigm of gun violence. Somebody is shot, and then we resuscitate them, and that's it. And that's also what we're measuring. We're measuring the cost of first-year gunshot wounds and emergency department visits. And it's missing a lot of the collateral costs of colostomy care for the rest of their life, spinal cord injuries for the rest of their life, and so on. And we're also missing the secondary victims. So we know that people who are victims, who witness violence, are also suffering from discrete mental and physical health problems. And relative to this, working at one hospital, I took care of a gentleman who was shot point blank in front of his daughter. And when I delivered the news that I couldn't resuscitate him, and I told her that he died, the daughter revealed some information that she was being abused by the assailant. And 4 months later, she came to the ER as an overdose. And she required an ICU stay of several days. And her experience, her number is not classified, as far as I can tell, in the gun violence numbers and costs that we're collecting. So after that shooting, and after others that I then took care of, I would take care of my colleagues, I take care of nurses, and I take care of paramedics that were traumatized by this. And I don't know, we haven't captured how many people are actually being seen and seeking health care. Those numbers, those ER visits, those medications, those follow-up appointments are not being tracked. We also know that violence, as we discussed earlier, has infectious qualities, and that it inspires emulative behavior and causes retaliation. I have seen this, and we ask ourselves, well, what can we do to interrupt this chain of violence? Because we have opportunities in real time. And we know that the opportunity for primary prevention is with us all the time. This is a case from my town. It's not my specific case, but I've had a half dozen like this, where essentially somebody does something scary in the community, the police come or someone intervenes, and there are no threats or injuries, and the person is brought to the hospital on a welfare check because it's a mental health problem. And then it's up to us to decide what to do. And because we are continuously in this situation where we are being asked to be the arbiters of risk without any guidance, it's important that we at some point decide what we need to do, even with whatever evidence we have. So when we apply the medical model of disease to this problem, I kind of look at it like any other health problem, because where I'm seeing these patients is when they first express their risk factor or when the risk factor escalate. And if we are able to intervene effectively, then we can prevent the shootings. And I have partners that I know have intervened and prevented a mass shooting. There was an episode weeks after Newtown where a partner identified a person at risk, and following that, there was another one. So we can't, again, measure prevention, but we can estimate it. So if you were to look at the true model, a medical model of a firearm injury, is very complicated, right? Because we have risk factors, and then the shooting, and the resuscitation, and the retaliations, and then those risk factors, and then those other sequela. So what we hope to accomplish, at least here today and moving forward, is identify what are the points of contact for physicians who are working in clinics, in ERs, so that we can identify those at risk, that have the latent risk, that are having their first expression of risk factor. What can we do when it escalates? When we aren't able to prevent a shooting and we have to deal with the side effects and the consequent trauma, what can we do to mitigate the secondary effects of gun violence amongst our patients? So that next time this happens, perhaps if I had the opportunity in that situation, if I had an intervention to this girl who witnessed her father's death, what could I have done that maybe she wouldn't have had to go on and feel the need to harm herself? And this also relates, again, to the costs, because none of the costs associated with the consequential trauma is being, as far as I know, categorized. Thank you.